Currently, I would like to introduce Todd Maddox, PhD and Vice President of Research and Development at Applied VR, to the stage to talk about the promise of VR-delivered skills-based therapy for chronic low back pain.
Thank you. Okay, we're ready to get started here. Oh, so I don't get to see it here. That's fine. I tend to pace. So what I'm going to do today is I'm going to talk about, summarize 2 randomized control trials that we've completed over the last 4 or 5 years, looking at a VR-delivered, skills-based, actually FDA-authorized therapeutic program now for chronic low back pain. Where is the deal? Let's see. There we go. Okay, so just a little bit about me, because I'm a little, I guess not a little, I'm a lot unique. So I had a 25-year career as an academic. I got a PhD in psychology a long time ago. And really the last 15 or so years of my academic life, I really focused on neuroscience, the neurobiology of learning. So I ran a lab, trained students, wrote grants, of course, publish or perish. That's the way it is in academics, so published a lot of papers. And basically, you know, big numbers, but I did this for a long time, so not any more impressive than most academics. Okay, virtual reality as immersive therapeutic. So, you know, what is therapy really involve? It involves getting rid of maladaptive behaviors and thoughts and replacing those with adaptive behaviors and thoughts. That is, it's about learning and it's about unlearning. That's something I know about because that's what I studied as an academician. This involves structural and functional changes in the brain. So that's what learning and unlearning is. The brain is plastic. The cool thing about VR and why I really dove into this field when I left academics about 6 years ago was that VR, simply put, is a learning machine. You put on a virtual reality headset, you immerse somebody in some therapeutic environment or game-based environment or whatever you choose as a content creator, and you are broadly engaging the brain. So really supercharging learning and unlearning, which is a truly fascinating thing. So VR has this potential to really increase the effectiveness and speed of therapeutic change. All right, let me now talk about the product. So again, FDA authorized. We call it Reliever. Not sure why there's an X at the end there if you're not pronouncing it, but that's the way it works. Okay, there's an urgent need right now, right? Like, a third of people in the world have some form of chronic pain, which is kind of blows me away. We know all about the opioid epidemic. Opiates work on the biological part, but we know that with pain, it's biopsychosocial. Okay, so we have this need for non-pharma therapies that are, obviously they need to be effective. You want people to be able to use them in their home, to be able to administer it by themselves. You want them to be low risk and to have consistent delivery. So one of the things about this program, because it's a skills-based program, is that we want the ability to have repetition so that we can build these pain coping skills and habits. And again, VR, this learning machine, has that potential. Okay, so one of the things I really like, and I didn't build this therapy existed when I started with the company about 4 years ago, but I really like the way it was developed. First thing is went to a really smart individual who studies chronic pain. This is Beth Darnall. She's at Stanford. She knows the literature inside and out. And the starting point was decades of research outside of VR, set VR aside for a second, decades of research on therapies that are known to work for treating chronic pain. CBT, meditation, mindfulness, deep breathing. And they work, and the way we quantify they work is with something called an effect size. So the effect sizes, depending on the study, range from 0.3 to 0.7. So these therapies work. They've been studied a ton, right? Scientifically validated. The innovation of what we do at Applied VR is that we take these therapies, we extract the foundational principles that we can then use with our VR content creators. We can take those principles and build VR content that captures those principles and then present it in VR. Remember, VR is this learning machine, so it broadly engages all these parts of the brain. That's over here on the left side. Experiential learning centers, cognitive centers, emotional centers, behavioral learning centers. And when you do that, take these foundational therapies, effect sizes of 0.3 to 0.7, build this VR content, present it to patients, you now have effect sizes in the 1.0 to 1.3 range, which is what we got in these 2 randomized control trials. It's a 56-session program. The dosage is 1 experience per day. They range from 2 to 15 minutes in length with an average duration of 6 minutes. 6 minutes a day in VR in the comfort of your home. That's the therapy. It is a fixed sequence, a fixed therapeutic sequence. There are a lot of VR therapies out there that use a library. Libraries are great for particular use cases. In this case, fixed therapeutic sequence, which makes sense. Some key factors here. You've got these experiences 1 per day. There's lots of lookbacks. Okay, so in order to build habits and skills, you need this repetition. Okay, so I'm going to summarize 2 randomized control trials. There's a lot that's similar about these 2 trials. First, half of people got, randomized, half people got the reliever device, 3D, immersive, VR-delivered therapy. Half got an active sham, so sham VR. Basically, it's like a big screen TV inside the VR headset. But everybody got the cool VR device, right? So we're controlling for that. 2 separate trials. The first one I refer to it as the pivotal trial. It had about 200 individuals in it, fairly homogeneous, mostly women, mostly white, middle-aged, moderate socioeconomic status. These were the data that we used to get FDA authorization. The second trial is our Health Economic Outcome Research Trial. I abbreviate that to HEOR. It's about 1,100 individuals. We spent a lot of time trying to get better racial diversity, more socioeconomic diversity, not all women, nothing against women, et cetera, et cetera. A breadth of ages, et cetera. All double-blinded, all decentralized. This was a trip for somebody who ran a lab for 25 years and was known as the guy who ran all the, we ran tons of subjects through our lab, decentralized. I mean, 1,100 people recruited in like a few months. Kind of blew me away. Okay, if you want one slide from my talk, this is it. This is the summary slide of essentially all the data. So our primary endpoints were pain intensity. In the last 24 hours, how intense was your pain on a scale from 0 to 10? 0, no pain, 10. It's brutal. I can't think of anything else. The second primary endpoint is pain interference. How much does your pain interfere with things like activity, sleep, mood, stress? We randomize people. We get that survey data. We have them go through the 56-session program, and we ask them the same question at the end, and we're looking for reductions in pain. In the pain literature, a 2-point reduction is considered clinically meaningful. That's what the MCID is. So we're looking for 2-point reductions. Okay, great. Across the 2 trials, and I'll break this down in a little bit, we had at least 2-point reductions in pain intensity and pain interference across both trials. Great, that's an average, that's not everybody. That's the average measure. How many people got some relief? Maybe it wasn't 2 points, maybe it was a 1-point reduction, but they got some relief. Overwhelming majority of individuals, 90% of people got at least some relief, and their average reduction was 2.5. So again, over the MCID. What if we up the ante and we say, okay, not just any relief, how many people got at least a 2-point reduction in intensity, interference, or both? That was about 60 to 70%. So it's working in the aggregate, it's working at the individual level. They send the device back. Then what happens? Does their chronic pain come right back? No, it doesn't. It's quite durable. And in fact, in our pivotal trial, we've gone out to 24 months. In our HEOR trial, we've gone out to 12 months. We're training skills, we're training habits, we're giving people things that they can take home with them, which is where they learned it, but without the VR device. The device is reusable. Actually, these last bullets I'll break down later on in the talk. This is a low-risk device, safe for in-home use. That's really key. I'm going to skip this because I sort of talked through it. Okay, so let me just sort of break the data down a little bit more, a little repetition here. The pivotal trials on the left side, the HOR trial on the right side. The orange bars are the pain reductions for reliever. The gray bars are the pain reductions for the sham. 2 points that I want to make here. First, at the end of treatment, after the 56 sessions, we had at least 2-point reductions for pain intensity and all measures of interference in the pivotal. In the HOR, we had a bunch of measures of interference, but we just aggregated them. So 2-point reductions, which I said before, but now you can see it broken down, and statistically larger than sham. Okay, so those are the two main things that you want to find, and we found those. How many people got some relief? Right now I'm breaking this down by trials. 88% found some relief at the end of treatment in the pivotal with an average reduction of 2.6, and a little bit more, 91% in HEOR with an average reduction of 2.4. What about durability? So in our pivotal trial, we followed people all the way out to 2 years. So I have the 6-month data and the 24-month data. And these are all published, by the way. This one I just revised and resubmitted, fingers crossed. 12-month data for the HOR. We're going to track these people to 24 months as well. Again, same format. We're not always seeing 2-point reductions on average, but we're seeing it in many cases. And in most cases, statistically larger reductions for the reliever device than for the sham. So again, we're training skills, we're training habits. We're not just dealing with pain in the moment, we're giving people things that they can use later. Sustained pain relief. So, I said how many people got some form of relief at the end of treatment. We'll take that out to 24 months. That would be this bar right here. Almost 80% of people still had some pain relief even 2 years later, and 87% at 12 months in the HOR trial. Okay, talk a little bit about usability. There's this really cool survey out there called the System Usability Scale. It asks you questions about the device. This isn't evaluating the therapy. How much did you like the therapy? It's really about how easy is this device to use. And what's cool is that there's benchmarks. So a couple of points. First thing is, notice I have 2 orange bars over here. One is for our pivotal trial, one is for our HEOR. We actually made some improvements to the device in between those 2 studies. Our product team has access to the back end of the Pico, and they just made it even easier to use. And that was reflected actually in the data. Extremely easy to use device. If I can use it, anybody can use it, because I'm not very tech savvy. It's easy to use. It's engaging, and people used it. We asked people to do 1 session per day, so we would predict if you're doing this perfectly, you would average 7 sessions a week. Well, we're getting around 5.4 in the pivotal, 4.7 in HER. So, 5 times a week, right? That's pretty good, and it's effective. And people liked it. How satisfied were you with the therapy? So now we're switching to the therapy. Did you like the therapy? Yeah, people love the therapy. And again, low risk, easy to use. Some people would get maybe a little nauseous. You take the device off, you put it on again later, and you're not nauseous anymore. Or a little bit of neck pain or something, you just got to find the right position to lie down in or sit up in or whatever. So extremely safe. This slide is really busy. I'm just going to talk you through it. In the HEOR trial, we had almost 600 people in the reliever group, which means that what I can do is I can look at clinical effectiveness, I can look at how engaged people are, how much they're using the device, and I can look at how usable it is for men versus women, for 65 plus versus not, for white, black, etc. At the highest level, and this actually literally should come out this week in Journal of Medical Extended Reality. I did the proofs a couple days ago. No differences for clinical effectiveness. You still hear this, oh, well, older people, they don't really use devices. I don't know. That's not what we're getting. It's just as effective. In fact, one of the few effects that we got was 65 plus used it more than less than 65. So go figure. Who does this work best for? So this is a question that we clinicians ask us a lot. These data, I certainly didn't predict this. Not surprised, I guess, but I didn't predict it. What we did was we did a big regression through a bunch of baseline variables in there to predict pain reductions. What we found was that people with high baseline pain interference actually got bigger pain reductions than people with low baseline interference, and the same for baseline intensity. So it seems to be working for people who are really, suffering more. Could have come out differently, but that's how it came out. And I think I nailed the time. I think I nailed that. Thank you. Yeah.
Have you gotten insurance coverage for the digital therapy?
We're working on it.
Are you facing the same barriers everyone else is?
I'm sorry?
Are you facing the same barriers everyone else is?
Yeah.
Approval, they want it clinically meaningful, they want value-based.
Yeah, so I mean, we have FDA authorization. We have clinically meaningful results. We actually are covered by one payer, but I think I'm not allowed to. This is hard for me because I'm just a scientist who, full disclosure, but I can't say who it is. But we're working on that, and we have an amazing market access team. But yeah.
Something like this could be a game changer, and I don't quite understand why, but insurance companies.
You know what? I'm so aligned with how you feel. Yeah, agreed. Yeah.
Thank you. Do you have any data on concurrent therapies or concurrent medication use?
Yeah, I mean, so we basically took all comers. So somebody might be on another therapy. We haven't really broken any of that down. Even with 500-600 people. So we did some analysis like on comorbidities, not so much on other therapies. That, future research. Great question. Future research. How's that? Yeah.
Great presentation, and I think it's a very well-designed study.
Thank you.
My question is, how do you envision, or have you ever considered to evaluate the reduction in the pain quantitatively with wearable device or EEG or anything that it's possible? And are you considering to do this kind of analysis?
Yeah, we did. So we did a pilot study with this really cool company in LA called Kernel. It's FNIRS, and of course the results are like differences of differences, which are really hard to follow. But at the highest level, there do appear to be some changes in the brain, which is exactly what we would predict. So, love to do more research on that. We're working. Yeah. Are we?
Yeah, we're good.
Okay. Sorry.
Yeah, I do see we have a few more questions. However, just at this time, we're going to move on and save your questions for after the session. Yeah, please.